Okay, why can't I get this to work now? I cannot believe this just did not connect. Can you guys still hear me?
Yeah. Yeah, I can hear you.
Yeah, I'm trying to get it to start the broadcast, and it's not starting for me. So, okay.
The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to the Antibiotic Stewardship in Nursing Homes webinar. Today's webinar will focus on partnering with your pharmacist. This is Deborah Curdy with the Quality Care Health Foundation. If you have any questions during the presentation, please feel free to type in your questions using the question panel on the right side of your GoToWebinar player. I'd like to start off welcoming Erin Epson from the CDPH. Erin Epson, MD, is a public health medical officer and assistant chief of the California Department of Health Healthcare Associated Infections Program. She is a board-certified infectious disease physician who completed medical epidemiology training as an epidemic intelligence service officer with the Centers for Disease Control and Prevention. Good afternoon, Dr. Epson.
Thank you, Deborah. So first, an announcement. If you weren't able to join us for the first and second sessions, we've placed recordings as well as example of an ASP policy and procedure document and an ASP notification letter to physicians that were shared by one of our colleagues at Diagnostic Laboratories on our program's website at the URL listed here. These are all available for free, and so please feel free to check them out and consider bookmarking this website because we'll continue to post recordings of these sessions. So today we're presenting the third session in this 6-part series, and today's session focuses on drug for nursing home antimicrobial stewardship, partnering with the consultant pharmacy. Next slide. The two presenters and discussants for today's session are Deborah Brown and Flora Bessie. Deborah Brown has been a pharmaceutical consultant for the California Department of Public Health for over 8 years. Some of her responsibilities include enforcement of state and federal regulations and licensed healthcare facilities, teaching at the department's Long-Term Care Surveyor Training Academy, as well as the Federal Long-Term Care Basic California trainings, and then as an education coordinator for the Pharmaceutical Consultant Unit. Prior to working at CDPH, she worked as a consultant pharmacist in long-term care. Flora Bessie received her Doctor of Pharmacy degree from Midwestern University in 2000, and then in 2002 she attained certification as a geriatric pharmacist from the Commission for Certification of Geriatric Pharmacists. She currently works in the San Francisco Bay Area as a self-employed long-term care consultant pharmacist. Dr. Bessie is actively involved in the California Association of Long-Term Care Medicine, or CalTCM, and is executive editor of their e-newsletter, The Wave. And so we thank both of our presenters for presenting today, and I'll turn it over to you, Deborah.
Thank you, Dr. Epson. I'd like to express my thanks for being asked to participate in this webinar. And also I'd like to recognize Flora for taking the time out of her busy consulting schedule to assist us. I'll start with the learning objectives. And although the regulatory framework has been mentioned during the first webinar of the series, I'd like to briefly summarize the public health impetus and regulatory framework for long-term care antibiotic stewardship programs. Also, a brief overview of the CDC 7 core elements of antibiotic stewardship in nursing homes with a focus on pharmacist collaboration. And lastly, Flora will present to identify specific strategies for long-term care consultant pharmacist support in implementing an antibiotic stewardship program. Next. Well, this 2007 illustration shows an MRSA superbug strangling Uncle Sam, stating that which does not kill me makes me stronger. We all recognize that in every healthcare setting and in the community that broad-spectrum antibiotics are probably overused and misused, and this has resulted in many multi-drug resistant organisms. And the public health problem is actually made more complex with the presence of antibiotics in our animal-based food sources. So it's no surprise that in 2014 the President issued an executive order directing the launch of the National Action Plan for Combating Antibiotic-Resistant Bacteria. The plan mandated national organizations such as Centers for Medicare and Medicaid Services and Centers for Disease Control to issue guidance and best practices for antibiotic stewardship to healthcare settings, which of course includes nursing homes. Next. The 2013 data from CDC showed an alarming number of illnesses caused by antibiotic resistance nationally, over 2 million patients with over 1% mortality. With regard to Clostridium difficile infections, the mortality was 5.6% based on 250,000 patients with drug-resistant infections. Clearly, we have a nationwide problem that needs to be addressed by all healthcare providers. Next. CDC's concern actually should be shared by all of us. We know that, according to their data, up to 70% of nursing home residents receive one or more courses of systemic antibiotics per year for various indications, and up to 75% of antibiotics prescribed in nursing homes may be unnecessary or inappropriate. And when you consider the potential for significant harm in the frail elderly, who typically, as we all are aware, have decreased clearance of medication due to decreasing renal function and increasing half-life of many medications, have multiple disease comorbidities, are receiving many medications, and are actually at risk for increased adverse drug events and interactions because of all those factors. They're also at risk for serious C. difficile infections or colonization with antibiotic-resistant bacteria. This is a big concern and is a big priority because in addition to the problems with harm in the elderly, millions of dollars are spent annually on antibiotic use in nursing homes alone. Next. Currently, the guidance at F441 includes language related to review of antibiotics to monitor appropriateness, including the support role of the consultant pharmacist who does their monthly medication regimen review. However, the CMS proposed mega rule, which was published in the Federal Register in July of 2015, actually expands this requirement. And Dr. Stone did discuss this in great detail during the March webinar, but I just wanted to reiterate that the proposed mega rule includes proposed revisions to F441 and a more robust infection prevention and control program, which is overseen by the Infection Control Program Officer. At this point in time, we haven't received any additional information from CMS regarding the implementation of this rule. The public comment period, as everyone knows, is closed, but we have not received additional information as to when and if this will be implemented. Next. This particular slide also reflects previously discussed information by Dr. Epson during the March webinar, and it has to do with the new requirement based on a Senate Bill 361, which was chaptered in October of 2015 and adds Section 1275.4 to Health and Safety Code. And the implementation date of the antimicrobial stewardship policy implementation is January 1st of 2017. And the language of the regulation indicates that the policies will be consistent with guidelines developed by the Centers for Disease Control, CMS, Society for Healthcare Epidemiology of America, or similar recognized organizations. And I wanted to mention here that also CDPH issued an AFL shortly after this statute was chaptered. AFL is numbered 15-30. It was issued on December the 30th of last year. And the guidance on that AFL indicated that facilities should contact their local district office if they have questions about the AFL itself, or if the facility has questions regarding a stewardship program implementation, to contact the HAI program, and the link is there. And it's my understanding that the HA program has done some outreach with volunteer facilities to help them with their antibiotic stewardship programs, has been doing that currently. Next. As part of their licensure requirements, skilled nursing facilities must have an infection control committee that meets at least quarterly and includes a pharmacist. And you can see the information there. It's under section 72525. And section C indicates that, again, that it will include a pharmacist among other key personnel in the facility. And the committee must establish, review, monitor, and approve policies and procedures for investigating, controlling, and preventing infections in the facility. And also with regard to maintaining statistical information regarding types, sources, and locations of infections within the facility. And so, as you can readily see, the Infection Control Committee provides an ideal platform for the development of an antibiotic stewardship program, and that requirement's already in place. Next. What is antibiotic stewardship actually? Well, the CDC's definition reflects a facility's ongoing commitment and activities that optimize treatment of infections while at the same time reducing adverse events such as microbial resistance, medication toxicity, and the emergence of Clostridium difficile that are can be associated with antibiotic use. Next. There are a number of relevant medical journals that support the role of the pharmacist in antibiotic stewardship. I'm going to be providing a couple of those for examples for you so that you can obtain additional information if you want to. This source is from the Annals of Long-Term Care. They published an article in April of 2011, and they clearly delineated the pharmacy as a key player in collaborating regarding antibiotic stewardship. Next. In 2012, the Annals of Long-Term Care published another article, and it was entitled Pharmacist-Led Model of Antibiotic Stewardship in a Long-Term Care Facility. And the key ideas here, the key takeaway message is regarding the promotion of safe and ineffective medication use, which is the pharmacist's expertise in long-term care facilities and actually in any healthcare setting. Although this model had to do with pharmacist-led model, you know, we certainly understand that pharmacists are contracted in long-term care facilities, and so this may be a little pie in the sky for what is achievable, but I think that the takeaway message has to do with the expertise of the pharmacist. Also, the Infectious Disease Society of America has very much recognized the team value of the pharmacist's expertise, and a very good reference document is the paper, the evidence-based guidelines position paper that was released in April of 2016 this year, which included some important pharmacy-related interventions. Some of them are hospital-based type interventions, but they have good information about long-term care facilities as well, and the role of the pharmacist. Next. Dr. Stone, in the March webinar, did review the CDC 7 core elements of antibiotic stewardship. However, what we wanted to do here was summarize, just provide a summary of these and focus on the support role of the pharmacist in stewardship activities in long-term care facilities. So, of course, the first element is leadership commitment, and the pharmacist can definitely be a part of the fabric of the culture of culture change, which promotes antibiotic stewardship. So that's really important, and it's a very basic need. Next is accountability, and accountability has to do with engaging the consultant pharmacist. And since the consultant pharmacist has to review the monthly medication regimen review, they can actually provide valuable feedback regarding antibiotic use data and very nicely support the facility's quality assurance activities surrounding antibiotic stewardship. Next. Of course, with regard to drug expertise, the consultant pharmacist is first on the list. And consultant pharmacists do function very well as drug therapy experts. They maintain a consistent monthly presence in nursing homes due to the medication regimen review process, and it's likely that many pharmacists will develop additional training and expertise in infectious diseases and antibiotic stewardship as time goes on. The next item is taking action through policy and practice change to improve antibiotic use. Pharmacy interventions to improve antibiotic use could actually extend beyond the consultant pharmacist to the dispensing pharmacy, including the timely review of culture data and recommendations for treatment interventions if indicated. So there's actually an additional role for the dispensing pharmacy to assist with this endeavor if nursing homes would like to request that information and partner with the dispensing pharmacy as well. Next. Tracking and reporting antibiotic use and outcomes does represent a true collaborative effort that optimally will include pharmacist support. It's really important to know where you've been and where you're going, and to celebrate the improvements that happen. And by tracking and reporting antibiotic use and outcomes, the impact of new interventions can be measured. Process measures include concurrent review of resident medical records for new antibiotic starts to determine whether the facility guidelines for clinical assessment, documentation, and antibiotic selection were in accordance with facility policies. This is an important QA activity, and this is also a very important area where the pharmacist can support the facility team. Also, antibiotic use measures will help you determine patterns of use and the impact of new stewardship interventions. Usage patterns are actually valuable from not only a stewardship perspective, but also a public health action perspective. And hopefully, as more facilities are implementing electronic health records, this will enable data collection and allow the possibility of integration with pharmacy and laboratory data systems even. Antibiotic clinical outcome measures, such as the rates of incidence of Clostridium difficile infections, antibiotic-resistant organisms, or adverse drug events, can readily help facilities demonstrate improvement in their stewardship activities. This is another really important area where the medication regimen review can improve resident care and can help the facility. And since pharmacists are drug therapy experts, they can readily detect the emergence of adverse drug reactions and report those in a QA format as well. Next. Well, the last element is education. Last, but also very important. And it's important to make sure education happens with everyone, not just the staff. They're also the residents and their families. And this is a really key role where the pharmacist can support the facility. Education should be considered not just an initial effort, but an ongoing effort too. And pharmacists can support education of clinical staff through updates, such as the recent Food and Drug Administration safety announcement advising that the serious side effects with fluoroquinolone antibiotics, such as Cipro, Levaquin, and Avalox, generally outweigh the benefits for patients with uncomplicated bronchitis, urinary tract infections, and sinus infections. And the potential serious side effects could include tendon, joint, muscle, and nerve pain, possibly even irreversible. So it's important that the facility have discussions like this as well to decide what antibiotics should possibly avoid and maybe some risk-benefit parameters that can be considered. So this concludes a brief overview of the CDC 7 core elements of antibiotic stewardship with a focus on pharmacist support interventions. CDC encourages nursing homes, of course, to select 1 or 2 activities to start with, and over time, as improvements are implemented, expand the efforts to add new strategies to continue improving antibiotic use and the clinical care of residents. And now I'm going to hand the presentation over to Flora.
Thank you, Deborah. Next slide, please. So in developing a process I've just described that would incorporate the 7 core elements as described by the CDC, a lot of what we're already doing encompasses that. If you look at your dispensing pharmacy, if you're on a traditional dispensing system where you get blister pass cards, your pharmacy.
Laura, we can't hear you. Erin, can you hear Flora?
Try to send a message.
It looks like her phone was just dropped. One of those little technical difficulties. We'll get Flora back in just a second. Thanks for your patience.
Oh, sorry, this is Flora. I'm back.
Okay, good. Thanks.
Hello?
Thank you.
Okay, sorry about that. I don't know what happened. But so many of the stewardship activities are already being done. The question is, how are they being documented? In terms of developing a facility-specific program, I advise facilities right now, let's start with a simple spreadsheet. What symptom occurred that caused us to call the doctor, and then what was done next? Was there a culture done? If an antibiotic was started, what was the reason for that antibiotic to be started? Was there a stop date with the order? And did the patient have any adverse reactions? So next slide, please. Those are things that we can easily do, and it would complement the systems we already have in place. Again, reviewing of antibiotic prescribing is done usually at the dispensing pharmacist, by the dispensing pharmacist at the pharmacy. But in the world that we live in with internet-based charting, does your pharmacy have access to your internet records? Are they able to look at labs online to assess, to see if the cultures and the antibiotic that was prescribed is appropriate? Is the dosing appropriate for the patient based on renal function? We live in a world now where we have access to this. I work at several facilities where you can only access their internet-based charting on their Wi-Fi in their facility. I understand that for security purposes, but I also think it limits what you're able to achieve and the collaboration you're able to achieve with your dispensing pharmacist, or even if your consulting pharmacist is not at your facility. And then again, drug interactions are identified by the dispensing pharmacy, and that's something that your consultant pharmacist is also available to help with. Establish that communication with your consultant pharmacist in terms of when they're not there, how do you get in touch with them? And also, do you know how to get an intermediate medication regimen review by your pharmacy? What's the procedure? So if that's something that you're not familiar with, and that regulation went into effect in 2006, that short stay residents and residents with a change in condition need to have a pharmacist review. What's your procedure for that? And of course, the administration of antibiotics, the appropriate timing, those are instructions that come to you from your dispensing pharmacy. Now, if you're not getting the traditional blister pack card and you have an automated dispensing unit in your facility that you take your medications out of, it's important to find out how your pharmacy is communicating some of these instructions to you. It may be via fax. How do those instructions that appear on the fax get into the MAR where the order is written? So just things to consider, questions to ask of your dispensing pharmacy and of your consultant pharmacist. Next slide, please. And then again, tracking. You know, this is something that Deb talked about on her last slide, and I think it's something that could very easily be done. I was at a QA meeting yesterday where the lab provided an antibiotic-gram, which was perfect. But I think that's information that we could also be tracking in the facility with a simple spreadsheet, and it could be an arm off of the infection control committee that meets quarterly. And I attend many QA meetings, especially in a month like July, and I feel like, you know, the DSD at the facility reports the numbers of infections that occurred over the past quarter, but we don't get any, you know, there's no meaningful discussion based on that. And I think that's what stewardship is taking what we're already doing and having meaningful outcomes and monitoring meaningfully versus just numbers of infections that we've had. Next slide, please. So again, just as we've talked about, engage your dispensing pharmacy and engage your consultant pharmacist on what is already being done and what can be done to improve. I feel not improve, but better document the activities that everybody is already doing. So that's something to sit down with your dispensing pharmacist or your consultants if they work directly with the dispensing pharmacy to discuss what's already being done and what can continue to be done and how it's going to be documented. A lot of the consulting software that's being used talks, quote unquote, talks to the dispensing software, but that's usually a snapshot in time. I feel like the most accurate data of antibiotics dispensed to a facility can be pulled by the medical records department of a facility. I would rely on that information more than I would on what a snapshot that I might get from a dispensing pharmacy software that I'm downloading from as a consultant pharmacist. So next slide, please. And again, so you know, just circling back to a lot of the stuff that we're already doing, if we can set up a program within the facility, have goals to assess the start of an antibiotic before it gets started, and that wouldn't be something that just the physician does by starting a medication. It would be something that would come through the facility in consultation with the pharmacy, either at the pharmacist, either at the pharmacy or the consultant, and that would help determine if the medication is appropriate before we even start it. Now, if you have a medical director that likes to do a lot of labs or culture everybody that has symptoms of a UTI, if that culture comes back positive, is the medical director or the physician going to feel compelled to start an antibiotic? That's something that you should discuss as part of your quality assurance meeting to say, you know, what is the goal for treatment? When are we going to start treatment? And these discussions, I think, can help limit the inappropriate antibiotic use and just focus on when it's appropriate to use an antibiotic. Next slide, please. And again, in conclusion, you know, all this is based on antibiotic resistance. I was at a facility today where the hallway had multiple places where I could stop and, you know, sanitize my hands using an antibacterial hand wash, and that's great, but that's part of what's contributed to our antibiotic resistance as a society, as a community. our frail and elderly in the nursing homes are more susceptible, and they're, at a higher risk for infection, and they're at a higher risk for resistance. So it's really important that we work together as a team. Bring in your consultant pharmacist, bring in a representative from your dispensing pharmacy, because we're all available. There's resources available to you. They just need to be pulled together to set up something where we're all working together instead of just working in our individual realm. As a consultant, I review charts every month. I look at antibiotic orders to make sure that we have a stop date. I look to see if there have been any adverse effects or if there were any drug interactions. But recognize your consultant pharmacist coming in is doing a retrospective review. The review, in many cases, they're reviewing something that's already happened. We need to figure out how we can get this on the front end. And that's why I asked you to, recognize the intermediate medication regimen review process. How can you solicit a review without your consultant pharmacist being there? How can you ask questions of your dispensing pharmacy? How does your dispensing pharmacy send information to you about medications and how they should be given? Those are some of the questions that you need to ask and then incorporate into a systems process for antibiotic stewardship. Next slide, please. So this is a question section. Deb, did you?
I did have some other questions if you want to if you want to answer those first.
Okay.
Or do you want to go through your questions first?
Yeah, this is Erin. How about we go over these, these discussion questions first with Deborah and Flora, and then we'll move to questions from the participants.
That's a great idea.
Okay, great. Well, in anticipation of today's session, Deborah, Flora, and I all came up with several questions that we thought would be good for our panelists to discuss. The first couple of questions, relate to, training and education resources for consultant pharmacists. So the first one is about stewardship training or certification programs for consultant pharmacists. And so I'm wondering if either or both Deborah and Flora would like to comment.
Well, this is Deborah. CDC had a couple of good resources that I wanted to mention on this call. One of them it has an acronym of MAD-ID, and it actually breaks down to making a difference in infectious diseases. And there's a certificate program that they have available, and this is available on the internet. It's a 3-module program, and it is expensive. It's $500. Actually, that's a little less expensive than the stewardship program offered by the Society of Infectious Disease Pharmacists. They have a practice-based certificate program for antibiotic stewardship focused on the role pharmacists play in the appropriate use of antimicrobial agents. And I'm guessing both of these programs might be more geared toward the hospital pharmacists. I'm not sure. I haven't looked into them myself. However, in some discussion with American Society of Consultant Pharmacists California chapter, which I'm a member of, it sounds like ASCP national chapter is trying to work out something collaboratively with the Society of Infectious Diseases pharmacists to hopefully put together a program that's going to be reasonably cost and it's going to be geared toward the long-term care consultant pharmacists. So hopefully that will materialize. The other resource I wanted to mention, I don't know how many people, pharmacists that are on the call, belong to American Society of Health System Pharmacists. I'm also a member of that. And noticing I was on their website that they have some antimicrobial stewardship resources. They have a toolkit there. They have a statement on the pharmacist's role in antimicrobial stewardship, which is free and available on the internet. So those are just some resources that I wanted to mention. Flora, do you have anything else?
Yeah, no, that program that you were describing that is $750, that's a time commitment and it's a cost commitment. So I've been asked by several facilities if I have any sort of a certification for antibiotic stewardship, I do not, but I'm waiting for the ASCAP program to come out because I think that should be out by the end of the year to provide some certification or documentation that your consultant pharmacist has gone through a stewardship program, a stewardship training program.
Great, thanks. And were there any other, free, internet-based tools or other kind of education, activities that somebody might want to take advantage of?
This is Deborah, and there are so many things available on the internet. One of the modules that I wanted to mention first was the Agency for Healthcare Research and Quality has nursing home antimicrobial stewardship modules. There's a couple of different modules. They focus on the most common infections that are present in skilled nursing facility residents. And the second module also focuses on the antibiograms and choosing an appropriate antibiotic. So these toolkits are available. They're free. They're on the internet. I also, the Minnesota Department of Health has an antimicrobial stewardship program toolkit for long-term care facilities, and you can just Google these titles and you will get this information, and there is an amazing amount of information in there. They've got core tools, baseline assessments, infection surveillance tools, clinical decision-making tools, and a lot of other materials, including an educational module for nurses in long-term care facilities. C. diff infection prevention, UTI infections, asymptomatic bacteriuria, and skills fair questions for nurses. So there's just so much information available on that. I'm sorry that it was the Minnesota Department of Health and not California Department of Public Health, but I know the HAI, looking on their website, there's a lot of information there too. And a lot of it is related to hospitals, but it can be extrapolated to long-term care facilities in terms of best practices and how to kind of structure a good program. There's also, many of you are familiar with Health Services Advisory Group. They're a quality improvement organization. There is a quality improvement organization called Lake Superior Quality Innovation Network, which includes the states of Michigan, Minnesota, and Wisconsin. And they have long-term care antimicrobial stewardship program resources also on the internet. They have fact sheets even that can be given to residents and their families, and there's a number of resources there as well that I was able to find on the internet. So I think probably as time goes by, we're going to be seeing more information, but it's nice to have access to information that is no cost and actually helps us kind of understand what our goals are and how we need to get there. Laura, do you have anything else?
Yeah, no, I agree with what you just said, Deb, and I would just encourage the listeners to, start with something. Don't try to create a stewardship program that's going to be more than you can maintain. So start with some of the stuff you're already doing, and I would say do a better job of documenting so that if somebody does come in and ask you what's your stewardship program, you have a binder where you can open up and speak with them about it. So, there are a lot of tools available online for free. That's the great time that we live in. But, again, don't look at them and get overwhelmed and do nothing because there's too much to do. Start with what you're already doing.
Yeah, this is Erin. I think that's great advice, and certainly the CDC's guidance is to really work in a stepwise fashion, implementing a couple of activities to start with, and then gradually building over time. So the next question for discussion is about California Senate Bill 361. This was the legislation that requires skilled nursing facilities to have an antimicrobial stewardship policy in place by January 1st of 2017. And the question is whether or not this Senate bill includes language that specifically relates to the consultant pharmacist participation requirements.
This is Deborah. I'm going to answer that question. The language of the regulation does not specifically say consultant pharmacist. However, the language does say that the policies will implement guidelines, will be consistent with guidelines developed by the Centers for Disease Control, CMS, the Society for Healthcare Epidemiology of America, or similar recognized organizations. And I would again like to reference CDC's 7 core elements for antibiotic stewardship, because that is a standard of practice. That is probably the most comprehensive standard of practice that we have for long-term care facilities, in addition to the regulatory framework. And so our expectation as surveyors would be that as facilities are designing their policies, stewardship policies, that they would be incorporating those very strong elements of recommendation or recommendations by CDC and using the regulatory framework as defined by CMS.
Thanks. So I think we'll move on to the next question. And this is, are you aware of any model antibiotic stewardship policies that are being used by long-term care facilities that, that a facility could use to get started, not have to reinvent the wheel?
Flora, have you seen anything out there?
I haven't seen it from a facility perspective, but I have seen corporate, like, there's a group of nursing homes and there's corporate oversight, and the corporations have come out with policies. And Deborah, we spoke about this the other day. A lot of times those policies are pretty generic, which is not bad, because you don't want to have your own policy get you into trouble on a survey. So again, I feel whether we write it down as a specific policy or it's a systems practice that we implement at a facility, it's the outcomes that are going to mean more. So I don't know of any specific policy that's going to spell stuff out enough to get started.
And I know it's daunting to think of recreating the wheel on this, but if I was going to be creating a antibiotic stewardship policy, I think what I would do is start with the regulation itself, Health and Safety Code, the statute, Health and Safety Code 1274.5 requirement, and the CDC core elements. And then I would delineate what my facility's goals are and scope, and basically who, based on the resources that you have available, and I think, resources can be unique to each facility, and then delineate who is responsible for what activity, and also to try to delineate what you're going to monitor, reporting of the data, and QA aspects of your program. It seems like those are just sort of some framework elements to think about as you create your policies.
And this is Erin. We have posted on our antimicrobial stewardship web page an example or kind of a sample of an ASP policy and procedure document that was shared to us by an infection control consultant with diagnostic laboratories. It is very similarly laid out to what you just described, Deborah, as far as organizing around the CDC 7 core elements. And so that might be another tool to use as sort of a starting point to then kind of tailor to your specific facilities resources and goals. And that's on the website. They showed the URL in the introduction. And certainly, if any of the participants have a policy and procedure document that they'd like to share as well, please feel free to get in touch with me. Would really appreciate additional tools. So the next question for discussion is about contracts. So are you aware of any examples of consultant pharmacy contracts that actually specify antibiotic stewardship activities in the contract?
This is Deborah. I'd like to answer this question first. One of the things I just want to say is, based on my experience as a surveyor, I've looked at a lot of pharmacy contracts, and one of the commonalities basically to all contracts is they usually mirror the regulations. They mirror the regulatory requirements. So from a licensing perspective, as I mentioned, pharmacists need to be involved in the Infection Control Committee and also the Pharmaceutical Services Committee by licensing requirements. And so from that perspective, usually all of those bases are covered without having to specifically mention any kind of current initiatives that need to be undertaken. Flora?
Yeah, I agree with you, Deb, and it's not going to be spelled out specifically as antibiotic stewardship, but this is what a pharmacist does. Reviewing appropriateness of medication therapy for a resident is what a pharmacist does, and being part of the Infection Control Committee, being part of the pharmaceutical quality meeting once a quarter, and recognize this. If you look at the regulation in Title 22, the pharmacist has to participate. It doesn't necessarily mean, given in a given quarterly month, I may have 3 meetings on the same day in 3 different directions, and I may not be able to get there. So, your pharmacist can participate in various ways. And I find it more effective, instead of having your pharmacist and medical director there for the general meeting, that a small breakout meeting takes place between the medical director, whether they call in or they're present, the pharmacist, the administrator, and the director of nursing, along with the director of staff development, that might be heading some of the stewardship activities. So, it's the communication part that I don't feel gets effectively done in the format that we have right now, because the contracts speak to, just as what Deborah said, they mirror the regulatory requirement of a consultant pharmacist.
Thank you. And then last question is, how much time do you think the consultant pharmacist should be allocating to antibiotic stewardship on a monthly basis?
So, Deborah, I can start with this. There isn't a specific time commitment, but what I can say is that your consultant pharmacist will have a limited amount of time. If you have 60 patients in your facility, they're not going to spend 2 days there. That's just not going to happen. So, okay, what resources do you have? You have your intermediate medication regimen review that can be done that when the pharmacist is not present. You can decide. I have a facility, a 200-bed facility, that asked me to audit all the AIDS tests in their facility and identify who's due for AIDS. Well, that's great, but recognize that your pharmacist has great clinical skills, and you might want to use that resource for something more clinical, such as antibiotic stewardship, versus a task that can be done by medical record. So, things to keep in mind in terms of allocating your pharmacist's time that you already have versus being concerned how much time should be spent on stewardship activities.
This is Deborah. I agree that consultant pharmacists have to really divide their time among many, many activities. Certainly the medication regimen review being the majority of their time that they spend in the facility. It seems logical that, and it depends, a lot of your facilities, the facilities may already have some systems in place already, but it seems logical that as the facility is developing some of these policies and processes and algorithms and some of the other things, whatever they decide they're going to do to move forward with this initiative, it seems logical that it may take more time in the beginning, but I think as time goes on, once you integrate all of those processes into the facility, it's a matter of just monitoring to make sure that the facility is compliant with those processes, and then the quality assurance aspect. So I think from a maintenance standpoint, it's probably not going to take as much time as possibly the initial investment.
Thank you. I think the last question here relates to tracking activities and whether or not any of the software programs that are used by dispensing or consultant pharmacists will actually specifically track or generate reports of antibiotic use measures. And examples of those would be antibiotic days of therapy, point prevalence of use or new antibiotic starts.
So yeah, this is Flora. This information is available, but again, it's at a point in time. So if you're looking over the past quarter, that information may not be readily available. So I think that it's best to track this in the facility because in a given quarter you may have a few antibiotics started or therapy continued versus the pharmacy having to pull it out of all the orders that they filled over that same time period. So yes, the information is available. I don't know how accurate it would be and how relevant it would be. I think it's best to track this in the facility with the help of your pharmacist, led by somebody such as the DSD at the facility.
Okay. I think you described in your talk about setting up like an Excel spreadsheet to do that.
Yeah. I've done that at some facilities and it's worked out really good because you can, and you can blow that up and put it on a screen during a QA meeting and everybody knows exactly what happened that caused the start of an antibiotic. So.
Okay. Deborah, did you have anything you wanted to add?
I think it's possible that a lot of these software vendors may, if people who are using those programs may be approaching the vendors and find out if maybe they have something under development. I've looked at their various websites and there was nothing obvious there, but there may be something under development that's going to help track all of this information for the facilities. And hopefully facilities will be able to use their software information with their internal software information to also help them track some of these parameters.
And in some cases, consulting software isn't even relevant because I have quite a few facilities that expect me to document within their charting system. So then, in that case, the consultant pharmacist software component is off the table. So we're just relying on dispensing records. Again, I found that what I get at the facility is far more accurate than any report I can pull off of dispensing software.
Okay, thank you. Deborah Curdy, I'm wondering, are there any questions on the webinar?
Oh yeah, there's lots of them.
Okay.
We have about a little less than 10 minutes, so we'll get to them. And then what we've done in the past, if we don't get to all of them, I have the questions recorded and I will send them on to Erin and Deborah and Flora, and hopefully we can get them all answered, within a week or so. And then I'll send out all the questions and answers to everybody after the fact, if that works for you, Erin.
Yeah, absolutely. I think that sounds great.
Okay, the first one, since skilled nursing facilities do not hire attending physicians, it is difficult to establish best practices with specific antibiotic therapies. Your recommendations?
Laura, I think this is a good one for you because you have probably some great collaborative relationships with physicians.
Yeah, I think it starts with the medical director, and I agree that a lot of times the physicians coming in are of the patient's choice. But I don't think it would take more than a brief conversation with any attending that comes in saying this is our practice. And if that's best suited to come from the medical director or the consultant pharmacist, then I think that's something that could be done. I found that many of the attendings that come in are very flexible because they work in hospital settings where they are, governed by formularies and probably a lot more than what we're expecting as part of the stewardship program at a facility.
Great. The next one, is it a mandate or requirement that the pharmacist must be a certified infectious disease pharmacist, or that there be an infectious disease physician on the ASP team?
I think pharmacists, yeah, go ahead, Deborah.
Oh, I was going to say, this is Deborah. It's important not to confuse the antibiotic stewardship requirements of hospitals with those of skilled nursing facilities. And at this point, there is no requirement to have those certified individuals on the antibiotic stewardship team in a long-term care facility.
This is Flora.
Thank you.
Pharmacists by training, we all go through virtually the same curriculum, and there's a huge focus on infectious diseases and antibiotic use. So this is something that's core to what we go to school for.
Great. Does the California law require that the entire program be written and established by 1/1/2017?
This is Deborah. So starting January 1st of 2017, we're going to be serving to that statute, Health and Safety Code, Section 1275.4. Now, does the whole program need to be implemented by January the 1st? I would say at the very minimum, it says, according to the requirement, it's adopt and implement a stewardship policy. I think what we would expect to see is that there is a framework of policies that have been developed and that there has been some kind of an attempt to implement those policies. And as we talked about with the CDC 7 core elements, I mean, certainly it would be difficult to adopt all of those simultaneously, but to start putting pieces of those in place. And I think that each facility needs to really do some self-examination about maybe what some of the most important, most critical elements of implementation are for them, what they need to do in terms of their unique population, the resources they have, details like that, that there needs to be an attempt to do some sort of implementation. And, you know, certainly there's CDC provided us with that checklist, that really nice checklist to find out, you know, maybe there are some elements that have already been implemented, and maybe there can be some kind of gap analysis about, you know, what you're doing and what you need to do, and just to do, you know, some analysis that way internally. And, you know, of course, definitely include the consultant pharmacist with that to come up with a framework of a plan. I wouldn't say that, well, January 1st is a holiday for one thing, so let's say January 2nd. I wouldn't say that the surveyors are going to be expecting extremely well-developed plans by January, but we're going to be expecting to see that those policies have been, that they have been approved by the, at least the Pharmaceutical Services Committee and the Patient Care Committee, and that, that there is an attempt to implement those plans.
Great. Deborah, you mentioned some free modules on the internet where a couple people were wondering whether you have the links to those. Again, this is something I'll send you, and maybe we can post them, or I can send it out to all of the attendees, you know, within a week or so.
I would be happy to do that. If you want to, if we want to collaborate and I can provide you with those links, I would be happy to do that.
That would be wonderful. Thank you. And it says, are there any resources to help gauge survey pharmacies and or SNF's current ASP efforts?
I'm sorry, could you repeat the question?
Are there any resources to help gauge / survey pharmacies and or SNF's current ASP efforts? So they're wondering if anybody is already doing this, and if there's anything out there that's a resource for other skilled nursing facilities to take a look at.
I know another consultant pharmacist who said that one of her facilities is doing that. I wouldn't want to mention the name of the facility. Flora, do you have anybody in your service area that already has a program rolling?
So I have, as a matter of fact, I was at a QA meeting yesterday, and I have a facility that's already tracking some of the stuff we talked about on an Excel spreadsheet. They're doing a lot of the stewardship activities. They're just not calling it that. You know, they want to kind of buffer up their front end with hand washing technique and hand washing observations, and, you know, educate the CNAs on that. So That's the closest I have so far. But they have the framework in place where they just kind of have to build around it and make it more robust. But they're already doing antibiotic stewardship as described by the statute.
They're just not calling it that.
Yeah, exactly.
And probably our last question, surveyors have recently stated that it's a requirement that the nursing home have an ID pharmacist on the committee. Is this required?
This is not a requirement. This is Deborah. This is not required.
Okay, great, thanks. And like I said, that pretty much is our time for today. I just want to let everybody know that you can obtain the CE hour by filling out the evaluation that you should be getting by email to you after this webinar. And then our next antibiotic stewardship in nursing homes webinar will take place on September 27th. So make sure you mark your calendars. Details and registration information will be available soon. I just want to thank Deborah, Flora, and Erin, as well as Clough and Cass, for joining us and taking your time to view this presentation. Everybody have a great day, and like I said, I will get those questions off to Deborah, Flora, and Erin, and hopefully within a few days we can get that information out to you. Please feel free to email me at dcurdy@cap.org if you have any questions. And again, thanks everyone.
Thank you. Will do.
Thank you.
Okay, bye guys.
Bye.